Good morning and welcome everyone. Thank you for joining us for this webinar, Maternity Services as an Integral Part of Family Hubs. I'm Jane Verkin, the Policy and Practice Advisor at the National Centre for Family Hubs here at the Anna Freud Centre. And I'm just going to run through a few housekeeping issues before we start. The webinar will be recorded and available as usual on the Anna Freud's YouTube channel after the event. Closed captions will be available during the webinar. Please click on the closed captions button to enable these at the bottom of your screen. Your camera and microphone will be turned off for the duration of the event and cannot be turned on. The chat function is disabled during the webinar. If you have any questions, please submit them via the question and answer function. If you can see that your question or a question similar to yours has already been asked, you can upvote the question by clicking the thumbs up icon. This will help ensure we answer the most popular questions first. If you have any technical issues, please put these in the question and answer function too. A member of the Anna Freud Centre team will be able to assist. And finally, if you find any of the sessions triggering and are affecting you personally, you can obviously leave the event at any time. And if you would like any support, there will be links in the chat function to enable you to access support. So moving on to the agenda. Over the last few years, there's been much highlighted on TV and in the press about the inequalities in maternity care. The latest Embrace report, published in October this year, Saving Lives, Improving Mothers' Care, which will be put in the chat, states that women are more likely to die in childbirth if they're from a Black or minority ethnic group, or older, or are from more socially deprived backgrounds. With the emotive media headlines that accompany such reports, it's easy to get into a blame game of who's responsible. But we need to remind ourselves that these outcomes relate to deeply rooted health and social inequalities that can't be addressed in isolation. I believe that we all have a role to play in ensuring that pregnant women and those with new babies receive the support and care they have the right to expect, and that where there is any risk of inequality, that these risks are recognised and acted on. It requires a collaborative response, and family hubs offer us this opportunity. The opportunity to develop a more integrated place-based system, enabling families to access early support on their doorstep. This will mean new and creative ways of delivering maternity services, as many of you are developing. This morning, we're going to hear how this is being addressed from different angles through policy, local practice, and the work of a charity who put a spotlight on the impact of birth trauma and are committed to make birth better for all. So we're going to move on to the agenda now, and our first speaker, Becky James, is probably very well known to many of you. She's a Regional Delivery Support Advisor at the Start for Life unit, DHSC. Before moving to the Start for Life unit, Becky worked in Cambridgeshire Local Authority in Children's Services. So over to Becky.
Thanks, Jane. I'm just going to cover a little bit around the policy and the expectations of the Start for Life and Family Hubs programmes in terms of maternity services and integration. Lots of this you'll be familiar with. You can find more information, obviously, in the government webpage and looking at the Start for Life and Family Hubs programme guide. And also you can contact one of the team or the National Centre for Family Hubs for further information as well. Next slide, please. So just a little bit of a recap to remind ourselves of the overall programme objectives ahead of the deep dive into maternity services and integration today. So at Autumn Budget 2021, the government committed £300 million for 75 upper tier local authorities to deliver the Start for Life and Family Hub services over the next 3 years. We know that family hubs are a place-based way of joining up locally in the planning and delivery of family services. They bring together services to improve access, improve connections between families, professionals and services and providers, and put the relationships at the heart of family support. Family Hubs offer support to families from conception to age 2 and to those with children of all ages, which is 0 to 19 or up to 25, with those who have special educational needs or disability, with a great Start for Life offer at their core. The national vision for Family Hubs model is a system-wide model of providing high-quality, whole family, joined-up family support services, delivering support from pregnancy through to the child's early years, into later childhood and into early adulthood if needed. Family Hubs should provide a universal front door to families, offering access to family support services across maternity, social, educational, mental health and physical needs, with a comprehensive Start for Life offer at its core. They should provide a local, non-stigmatising front door service, which is open to families when needed, and where families tell their story only once to a trusted team of professionals at the earliest possible stage. And hubs should be delivered with a mix of virtual and physical spaces, as well as outreach, where families can easily access non-judgmental support for challenges. So in a nutshell, this single gateway for family support services could improve join up between organisations, offer a whole family approach, with relationships at the heart of family help, manage statutory pressures more effectively and reduce waiting times for early help interventions, and ensure that families are offered support at the first time of asking. Next slide, please. So programme objectives, again, you'll be aware of this if you're working on the programme currently. Again, we're looking at that, offering that universal front door for families, and you can see here some of the key objectives that were developed as part of delivering the service. And particularly, I've highlighted there facilitating the join up of multi-professional workspace, enhancing capacity through new workforce models, and investing in multi-agency training. This was really highlighted as a need across the system to support families more efficiently and effectively, and also support services with supporting each other. Next slide, please. So part of the service expectations, again, you can see I've highlighted there, Start for Life universal services, so midwifery, health visiting, mental health, infant feeding, and safeguarding and SEND. These are part of the core services that would be expected by our 75 local authorities currently working on the programme to deliver as part of their Family Hub network. And there were a selection of minimum and go further expectations that local authorities were expected to deliver on. Next slide. So we can see here again, just to drill down into those core principles, access, connection and relationship should all be very familiar with. There's a clear and simple way for families of all ages to access support through the Family Hubs. And that's that concept of services without walls. The connection, services work together for families with a universal front door. Professionals work together through co-location, a common approach to their work. Joined up services underpinned by a strong leadership, shared data systems where able, shared training, and statutory services and local voluntary community services work together to support families. And relationships there, just prioritising relationships, a huge part of the programme, and building on family strengths. So relationships both between families and family hubs, but also professionals, and that's at the heart of everything that is delivered through Family Hubs. Next slide. So just a reminder of what we mean by minimum and go further. So as part of the programme, there were various different strands, various different pillars of work where we had listed minimum and go further expectations. Now, just to caveat this, of course, all local authorities have different starting points, they have different circumstances, different financial restrictions, expectations, for example. So I think we need to be really mindful about where delivery takes us over the course of the programme, taking into account those different starting points for all local authorities. But the minimum expectations there were required, local authorities were required to meet these within the 3 years of the funded programme, and go furthers where local authorities were able to, on a position 2, there were go further expectations that could be delivered to enhance the family hubs and Start for Life offer. So, for example, in maternity and midwifery, this looks like, and I'm just going to pull out some key bullet points here. So again, do find further information on the Family Hubs and Start for Life governance webpage and in the programme guides. But in the minimums, in terms of maternity and midwifery, integrating into the Family Hubs model, we hope to see services available at the Family Hubs, including Family Hubs providing a team base for midwives working in the local area to meet and work across disciplines and agencies, to provide a clinical and non-clinical space to enable midwifery teams to be based there and offer appointments there with a particular emphasis on initial booking appointments, providing a confidential space and working environment, having a connection to vaccination centres, having the ability to make referrals to obstetric or other secondary care services where available and needed, and provide expectant parents with the ability to access a range of locally available birth options where appropriate. And there are a number of other expectations, minimum expectations to be offered not through the Family Hub, but elsewhere in the network. So one-to-one home visits for midwifery, some virtual information, including static online information, or perhaps virtual services. Website communication channels showing up-to-date appointment clinics or drop-ins for families to access, and virtual access, including telephone appointments available. So the go furthers, again, just picking out a couple, if you're able to. There is a care continuity between midwifery and health visiting through joint working, improved sharing of information and or focused on postnatal handover, and if appropriate, including face-to-face handover from the midwife to the health visitor with the parent and carer within the Family Hub. There are newborn screenings offered, postnatal contraception is made available, vaccination services are offered actually in the Family Hubs, and Family Hubs again emphasising that ability to provide a team base for midwives to work in the local area and meet across disciplines and agencies, and providing that clinical and non-clinical space to enable midwifery teams to be based there and offer booking appointments there with an emphasis on that initial booking appointment. Next slide, please. So again, the breastfeeding, I thought this was important to put in just because they're cross-cutting within the obvious join up with maternity services and our VCS organisations. Lots of our local authorities have invested in both statutory organisations and VCS organisations to enhance the breastfeeding offer and to improve outcomes in their areas. And you can see here again some of those minimum expectations that were requested as part of that integration into the Family Hubs network. Next slide, please. So alongside this, some will be aware that we also invested £10 million into the Start for Life workforce pilots to be completed over 24, 25 and 23, 24 and 24, 25. And this was allocated to support innovative workforce models, which have been, which had the potential to increase integrations and had the potential to better support families and babies. So this funding particularly was looking at testing sets of core components, introducing additional innovations appropriate to each workplace, learning more about what works in different contexts to improve access, experience and outcomes with a focus on reducing inequalities, and evaluate what works to attract and retain skilled professionals needed to support families, including career development opportunities and pathways. Next slide, please. So these were the local authorities that are currently taking part in the pilots, and they're still ongoing. So they've been working on developing their work stream since autumn of 2023 and continue to work towards full implementation until the funding ends in 2025. So you can see Barnsley, their focus was to recruit more members to their existing and mixed skilled workforce. Islington were looking at enhancing their family health advisors role. Leicester was enhancing a work of collaboration of local councils, trusts and third-party organisations. Norfolk was developing their health visitor-led skills mix model, and Tower Hamlets is developing their existing skills mix model. So lots of integration, lots of cross-cutting work roles, lots of supporting those various parts of the system to work more collaboratively together. So early findings, this implementation is going well. However, recruitment has been a consistent area of challenge across all pilot sites due to ongoing national workforce shortages. And I think, members of the 75 local authorities working on the programme currently will echo that as being a real difficulty across the programme, let alone sort of, where we're really focused on integrating services and extending that capacity to the Family Hubs network. And an independent evaluation of the pilots is also being carried out, and we expect those findings to be released in spring 2026. Next slide, please. So some of the things local authorities have told us that have worked well in terms of integrating maternity services into Family Hubs. So co-location of services, we've seen that across most Family Hubs. That's been possible in a lesser or greater extent. Health visitors are more visible in the community. Having partners on site where possible has worked well. Having that multi-skilled workforce across centres, having regularly joined up planning meetings, more regular conversations and multi-agency boards. And we really hear that integration of staff on site has enabled those softer conversations that potentially you wouldn't have when we were working in a more siloed model, really helping to increase that level of support we can offer to families. Health visitors working from a location, a family hub navigator is approaching them, talking to them, they're having conversations about potential families that would be helpful to refer into services or cross over to services, refer into community services. So those conversations are much more able to happen now and really increase that multi-agency partnership working, as well as developing those relationships between services, knowing who the health visiting team is, knowing who the Family Hubs staff are, seeing those CVS services coming in, having those conversations, knowing what each other are doing. It really has helped to integrate those working relationships in a much more effective way. And what hasn't worked so well? Next slide, please. So more of the challenges, engagement and participation from GPs and midwifery. We know that these are stretched services. We know it's difficult to find the time to integrate in anything or have those separate conversations by, trying to do your daily workload, really safeguard your patients. Acknowledging that there needs to be, further redesign, looking at how our services integrate better. Still some working in silos. It's quite a natural way for us to work that we've worked for a long time. So making that change is really difficult. Obviously, those data sharing problems still exist. We really need to look at those and look at greater ways that we can help. And duplication of work, I'll just skip down to the bottom there, is still ongoing. So we still have some challenges. We still have some way to go with integration, but early indications are that through the Family Hubs and Start for Life programme, we are making effective changes to overcome some of those. Thank you.
Thank you very much, Becky, for setting the policy context. We're now going to move on and focus on practice. And I'm very pleased to welcome our second speaker, Nina Kazazadeh, who is Regional Chief Midwife for London. Her experience includes shaping and implementing national policy, acting as a midwifery advisor on NICE guidelines, and serving as a past president of the Royal Society of Medicine Maternity and Newborn Forum. She's passionate about addressing health inequalities and champions the integration of service users' voices in maternity services, and is leading talent programmes across London to cultivate a diverse and inclusive workforce. I also understand that Nina's studying for a PhD. I'm not sure how you find time for all of that, Nina, but welcome and thank you. Over to you.
Thank you, Jane, for that kind introduction. I'm delighted to be here with you all. As Jane said, the part of it, I think I'm delighted to be here, partially because my community career started as a Sure Start midwife over 20 years ago. So this is an area that's very close to my heart. And if you could just move to the next slide for me, please. I thought before going into discussing the opportunities within the family hubs, it'd be useful just to give you an overview of the maternity services across London. So, as you will see, there are 18 NHS trusts within London and 20, we provide maternity care across 20 maternity units, 26 maternity units, apologies. We have three freestanding midwifery-led units in London and one standalone private maternity hospital in London. As you will note, our birth rate has fluctuated over the last few years. So in 2022, the birth rate in London was just approximately 108,000 births, which generally at that time equated to about 18.5% of all England's birth, what we generally are equating to about 20% of births in England. You will see from the map that London is divided into 5 integrated care boards. You start from the top from North Central London, North East, all the way to South East, South West, and North West London. But what's unique about London is the close proximity of our geography, which really provides a unique opportunity for us to come together as one community to share resources, but also escalate and amplify best practices to benefit those who are coming through our doors, both our pregnant women, birthing people, babies, their families, and expectant parents. I think it's always useful to put things into context. And in London, one baby is born every 5 minutes. So within my 15 minutes of talk, we would have had 3 babies being born, which really does tell us the scale of opportunity for us to be able to reduce and tackle some of the inequalities that Jane was alluding to at the start of her conversation. If you move to the next slide for me, please. So where are we in terms of national context? As you know, maternity has been under a great deal of scrutiny due to valid reasons, and some of our providers across England haven't really been able to provide the service that our service users deserve, and there has been some shortcomings within that. So that has led to a number of policy reports, but also reports looking into areas where there has been shortfalls and failures. And each time a recommendation or report was published, that led to a huge number of recommendations. So the national team decided to support clinicians to be able to provide good care, to really merge all those recommendations. And that led to the publication of the 3-year delivery plan for maternity and neonatal services in 2023, which, as you will note, by the date is coming to towards the end of its duration, really. What's unique about this policy document is that's focusing on 4 large themes. One is around listening to and working with women and families with compassion, growing, retaining, and supporting the workforce, the culture of learning and safety, but also ensuring we have robust evidence-based practices and structures to reduce variations across England, but also for us in particular in London. So not having the ability, when you speak to women, unfortunately, one of the common recurring themes that we have heard from our families is that in some occasions they're not listened to. And that's one area that we really are keen to address. And part of that means to working with them to support and co-produce and drive the services forward. So if you just move to the next slide for me, please. So looking at the London context, as you know, the vision for London is to make London the world's healthiest global city and the best place in the world to receive health and care services. And this is not just the NHS London vision. This is a vision that has been co-produce with our local authorities, with GLA and other colleagues who are playing a role in the health and care, social care space. So looking more closely to the NHSC London priorities, we have focused on three particular areas. One is inclusion, improvement, and innovation. And the inclusion is particularly around addressing some of the inequalities that we heard in relation to maternity at the beginning. And in my own team in the region, our vision has been to provide a safe, equitable, compassionate maternity and neonatal care to our diverse capital city through what we refer to as 3 Cs. And so that's through compassionate leadership, co-production, and continuous improvement. The co-production is very key for us. The co-production is one of the reasons I'm here, and recognizing that as midwives, we don't have all the expertise, and that's why it's incredibly important to work with colleagues like yourselves and across the system to be able to drive the services and the improvements that we would like to see. And as part of that co-production, including our service users to help shape the service is incredibly important to us. And continuous improvement is an area that's, again, being in healthcare services, we know that if we don't continuously improve, we go backwards. So again, that's about how do we review, monitor, and continuously improve in order to maximize on the benefits and the expertise that we have around the table. I'm sure you have all had the chance to review the Lord Darcy's report. Within that, there are 3 key elements that's been suggested, and they're very pertinent to today's conversations, and that's why I wanted to bring them in here. So the 3 are moving from analog to digital NHS, recognizing that technology has moved and that has enabled us, and there are opportunities for us to utilize that digital, particularly if that's in relation to improving referral services and data sharing for us, but also making sure that parents and expectant parents all have access to their own health records to be able to be key partners and make decisions about the care for themselves, but also the children. Shifting care from hospital to community is a very interesting one. This is why we're here, and it really does lend itself very well to the family hubs. And as maternity services, we always have worked, we straddled between the two. We always worked across the community and the hospital, and approximately 80% of our services are actually offered in the community, both during the antenatal period, but also postnatal. So there is a huge opportunity for us to take advantage of the family hubs and work better collaborative around that. And again, moving from illness to prevention, if you consider what midwives do, a large portion of our work is around giving information. So health information and health promotion is an integral part of the midwife's job. Again, the family hub seemed to be an ideal place for us all to come together. So if you just move to the next slide for me, please. And how does that then come together around collaborative working across boundaries to give our families and their children from reception to age of 2, the best start in life? As I alluded to initially, as a previous Sure Start midwife and a children's centre midwife, I see the family hubs as an opportunity to build that on that legacy. And as I alluded to, the care pathways in maternities are as such that there are opportunities for us to work more within the family hub centres. The focus is about reducing inequalities here. It's important to recognise that the social determinants of health and inequalities are a very complex area to consider, and it really requires a multi-system approach to address them. It doesn't sit within one professional group, and we don't have the ability to do that. As you can imagine, there are educational needs, there are housing issues, and all other of issues that are quite complex. So therefore, a family hub will really lend itself uniquely to provide that opportunity to use and maximize the expertise of colleagues across the system to come together. I've just put the pregnancy test kit here, and that's because there are opportunities for us around health promotion, both preconception, but also for future pregnancies. And that's an area that the Family Hub will be absolutely key in bringing the professionals together. One of the unfortunately, the unintended consequences of the negative social media is that it has really led to erosion of trust in maternity services and healthcare services. And that meant that families, because of that fear of not being looked after, but also being listened to, are not really keen to access services. And having midwives and health visitors and other colleagues in their family hubs, it really is a great opportunity to familiarize the parents, the expectant parents, to the environment, to that community, and help to bring them to see what other services they can take benefit of, not just during pregnancy, but also after the baby's born, and all other range of services that are provided, be it social prescription or if you like, literacy issues, and also particularly around workforce and other areas. We talked about, I think it was Rebecca who alluded to the workforce. There are a number of areas that workforce where the multidisciplinary colleagues can come together, whether that's a midwife, health visitor, or family support workers, to come together and learn together. And we know that groups that learn together work better together. So the family hubs do provide that great opportunity to bring those multidisciplinary and multi-agency professional groups together to have a better insight of each other's expertise, but also to see how we can collaboratively support a family and provide a one-stop shop, if you like. And by doing that, perhaps streamline the pathways and referral pathways. And when I was trying to pull this slide together, it really took me back to an example that I experienced personally as a Sure Start midwife. And that was when I was in the local community in our shared space, where I was sharing the space with our speech and language therapist colleagues, the health literacy colleagues in the library, and other range of colleagues. On one occasion, when I went to see a family who had a 5 days old baby, and I noted that a toddler, about 3 years old boy, he was quite isolated and not very engaging. And it was only when I went back to our joint office and I spoke to our speech and language therapist and asked about her views on that. What we did was to arrange a collaborative visit to go back to the family with the consent, and by assessing that child, they realized that there were some delays in speech and development, and they were able to support that child before the child even entered the education system. And that to me was a success of that collaborative working. And the Family Hub really does create that space for us to come together. Some of the challenges that I have heard when I've spoken to our senior maternity leaders is do we have a space in order for them to come together? As we know, in order for midwives to provide healthcare outside the hospital setting, there needs to be a state that has specific requirements. And I think those are the areas that are easy to address if we are working together, and when we work together, to be able to make sure that not only the midwives are there, but all our health visitors are there. And I know Rebecca again alluded to the breastfeeding, and another success story that always stays with me is around one of our children's centres in Lambeth in London, who decided to actually apply for the baby-friendly status, baby-friendly initiative status as a children's centre in combination with a maternity provider. And that was a successful operation, it's fantastic to see how that training came together, how we trained all different professionals together around the foundations of that particular issue around breastfeeding and how we can support. And to me, those are the areas that we can build on. But it does require all of us to come together. And the golden thread for me and for all of us is around the family that we are looking after. And it really kind of makes me think of the proverb that it says really it takes a village to raise a child. And I think the Family Hub, it really does provide that opportunity for us to come together as a multi-agency professional group to do that. So thank you, Jane. And I think my last slide has my email address there in case any colleagues would like to get in touch. Thank you, Jane.
Thank you, Nina. That was really, really helpful. And I know that you can't stay for the panel at the end, and we're running out of time. So I know you've said that if people have any questions, they could email you. Is that still?
Yes,
okay?
Absolutely. Yes.
So you will get the slides afterwards. So do email Nina if you have any questions that you would like to ask specifically about maternity services. So thank you, Nina. That was really helpful. Look at kind of maternity services and the real need to collaborate in what we do to reduce inequalities for women. So thank you.
Thank you, Jane.
We're going to move on now to look at another practice example in Bristol. And very pleased to welcome Jess Bowe, who's a senior public health specialist at Bristol City Council. Jess has been working in public health for Bristol City Council since 2010 in a variety of roles, always focused on children and families. In her current role, she's had a lead for maternity and early years, and so she's been closely involved in the implementation and delivery of the Family Hubs programme locally. Her roles included providing public health leadership, developing Bristol's Family Hub needs assessment, leading the Family Hub's infant feeding workstream, and supporting links into the wider health system and services, and ensuring the Commission services support the Family Hub's vision. She's going to talk about how the use of data has integrated services around maternity. And when I heard her talk, I thought the example is really inspirational. So over to you, Jess, thank you. And also before you start, can I remind people about the question and answer function? We've got a panel at the end, so please submit any questions you have that you're thinking about so we can discuss them at the end. Thank you, everyone.
Thank you very much, Jane. Yeah, it's a real pleasure to be here today. So when I started my current role at the end of 2021, the maternity and equality guidance had just been published by NHS England. And at that time, COVID and the Embrace data have both shone a really harsh light on the stark inequalities, and addressing these disparities felt like it was becoming an even more urgent priority. As part of the guidance, there was a requirement for local maternity and neonatal systems to publish a maternity health equity audit and an action plan. And I'd say that these requirements really help to strengthen our partnerships with maternity, ensure public health outcomes were prioritised by a system facing many challenges, and also support a data-driven approach. Following on from this, obviously the Family Hubs programme has also really helped to increase our partnership working with maternity, and again ensure there's that really strong focus across the whole system on preventative and early support. And it was really helpful coming after Nina's presentation and hearing some of those more recent sort of drivers as well. Okay, next slide, please. So in terms of the maternity health equity audit, Bristol Public Health led on this piece of work, and I'd say we were in a really good position to do this as we received really excellent data from maternity. Establishing this data flow wasn't easy, it did take many years, but our audit was held up as an example of best practice by NHS England at the time. So you can see the aim of the audit here. So essentially it's to identify mothers and birthing people and babies living in Bristol, North Somerset and South Gloucestershire with the poorest pregnancy and birth outcomes in order to target resources to best meet their needs and reduce health inequalities. So I will start by sharing some of the key findings from the audit before sharing some of the work that has been implemented and the challenges we're currently facing. Although the audit was completed in 2022, this wasn't a one-off piece of work, so we update these analyses and share them with annually across the system. So the data presented in the following slides is the most recent. If we could go on to the next one, please. So this is just sharing some of the main findings around the risk factors for BNSSG women and birthing people. So we have seen a reduction in the prevalence of most of the risk factors that we have data on across BNSSG since 2013. And where national comparison data exists, we tend to compare quite favourably. However, we still, as it says here, have around 8% of women smoking at the time of delivery. And as we know, smoking is the single biggest modifiable risk factor for poor birth outcomes and a major cause of inequality in child and maternal health outcomes. So we've also, there has also been some indication of a rise in need and demand for mental health support across BNSSG over the last few years. And another risk factor which has really worsened has been weight. So currently, we have around a quarter of women giving birth with a BMI of over 30. If we could go on to the next one, please. So in terms of birth outcomes, across BNSSG, stillbirth and low birth weight rates compare favourably to national averages. And we found that most outcomes have remained fairly stable over time or improved across the region. So the following have remained stable: gestation at delivery, low birth weight, low APGAR scores. And those that have improved are stillbirth rates, breastfeeding initiation and NICU admissions. Breastfeeding rates, particularly in Bristol, are much higher than the national averages and continue to rise. We have quite a strong, long history of strong partnership work around this. So if you go on to the next slide, please. So what we also do is we've analysed the risk factors and birth outcomes by deprivation, age and ethnicity to identify the groups most at risk. So we've looked at this in a graduated way. So those that are in bold are where some of the starkest disparities are evident. And so sadly, and as you would probably expect, there's a strong deprivation gradient, and those living in deprived areas are at much higher risk than those living in more affluent areas for all the risk factors we analysed, except alcohol consumption and all the birth outcomes. When it comes to age, those in the upper and particularly lower ranges were most at risk. So there's a few stats I can share around this. So for example, 31% of under 20-year-olds were recorded as smoking at their booking appointment, which was over 3 times more than the average across BNSSG for all age groups. Stillbirth rates were around 4 times higher, and we only had around 44% of under 20 women initiating breastfeeding. And then when we looked at ethnicity, those women categorised as Black, mixed ethnicity, or white women were most likely to experience risk factors. However, Black or mixed ethnicity women were experiencing the greatest burden of poor outcomes, whereas white women were mostly experiencing the best outcomes. So there's some examples of this here, which you can see. Okay, so if we could go on to the next slide. So there has been a lot of work which has been implemented within maternity, focused on addressing inequalities. So I was just going to share some of these. So the BNSSG Maternity Equity and Equality Plan has now been published, and one priority in the plan is to join up and enhance delivery via transformed family hubs. The LMS have also established multi-agency equity and equality meetings, and they include a broad range of key stakeholders, and there's a really strong focus on prevention and early intervention as part of that. The ICB have also secured funding for an antenatal maternity health champions pilot, And the public health maternity data set was really instrumental in helping to sort of shape this, to identify the priority groups and what those kind of health priorities should be. In Bristol, maternity are part of both of our steering and executive family hubs groups. Maternity have also implemented an enhanced continuity of care model for Black, Asian and mixed ethnicity women and birthing people, which includes enhanced maternity support workers. And one aim of this work is to reduce late booking of antenatal care, which was an issue which was identified by the audit. And there's also enhanced maternity support workers who've been employed in areas of Bristol where the smoking rates are high and breastfeeding rates are lower, with that focus. Anti-racism Black Maternity Matters training has been rolled out across maternity. I've been on this training. It's really, really excellent. I can't sort of praise it enough, and it's been extremely well evaluated. Another really positive kind of driver for us is that the ICB have chosen maternity in early years as one of their priority areas. So work is kind of ongoing to agree the focus of this, but it's likely to be kind of integrated whole family working, with actions developed around improving intelligence sharing, co-location, joint commissioning and co-production. Public Health have also funded a post-pregnancy contraception pilot in maternity to ensure there's much more equitable access, and it's been very challenging. Not many areas have managed to implement this yet, despite there being various bodies recommending this, including NICE, but we will be sharing the learning nationally via published research. If we could go on to the next one, please. We've also we're also piloting with maternity health visiting and children's centres co-delivered antenatal classes, and this is a really excellent example of joint working, and it's been a gap in Bristol for many years. Alongside this, the ICB have funded a local VCSE organisation called Black Mothers Matter to deliver targeted antenatal education. As part of our Family Hub's delivery plans, we're also piloting infant feeding peer support on maternity wards. And we've also launched a new parent and infant mental health pathway, and maternity were key stakeholders in this work as well. Okay, if we could go on to the next slide, please. Thank you. So in terms of next steps, I'd say as ever, there's always more to be done. And across BNSSG at the moment, we would really like to establish a more robust information sharing process between maternity and local authorities, so that family hubs and children's centres can more proactively reach out with their universal and targeted offers. We do see some low take-up of some of the specific elements of that antenatal offer in family hubs and children's centres. And so we sort of want to address that, and also just make sure that access is equitable. At the moment, we are very much reliant on busy midwives staying abreast of and communicating the local offer, and there is quite a lot of variation sometimes within that offer, not just between different local authorities, but even just between different sort of wards in Bristol. It can look slightly different. And there's also really high staff turnover in maternity, which we know makes things really challenging for them. Along with many other trusts across the country, maternity use an online system called Badgernet, and this enables women to access information about their care. There's a leaflet section, and we've included all of our Family Hub's resources on there. One drawback of the system is that while there is the ability to send out messages, there's no ability to target these messages to specific groups of women. And prior to the implementation of Badgernet, we were working with maternity to agree that weekly reports with basic information and contact details of all currently pregnant women would be shared. So this was sort of replicating the process that's been established with health visiting. And we just wanted to make sure that family hubs and children's centres were sort of a routine part of that antenatal pathway. And that women kind of knew, and birthing people knew, what was kind of available locally to them. However, the issue we've encountered is that the questions and the appointment pro formas on Badgernet do not adequately ensure that women have consented to this. If we could just go on to the last slide, please. Thank you. So In some ways, the solution is quite simple, and we would just like the following question to be added to Badgernet. So essentially, do you agree to your information being shared with children's centres / family hubs so they can contact you about the support available? However, making changes to Badgernet isn't easy. Trusts can only submit 4 change requests per year, and we know that clinical safety issues will always be prioritised. So one way around this is by making this a collective ask from different trusts, and making this change would support many other areas to establish a similar process. So this is a bit of an ask, I suppose. And if you would like to add your support to this request that we're making, please do email me. And I'm also really happy to share more information about this with people. But otherwise that's it from me. And thank you very much for listening.
Thank you, Jess. It's really interesting to hear how a shared understanding of need is beginning to shape delivery, but that you also have come across the issues around sharing information, like I think so many people on this call have probably grappling with as well. So thank you very much. That's really helpful. We're now going to move on to hear from Islington. From Renata Morricone and Laura Harper about their integration in the early years. And they've been integrated in Islington for a long time. And you heard from Becca at the beginning that they're also one of the workforce pilots. So Renata is the Bright Start area lead in Islington and is leading one of the 3 Bright Start areas with a specific remit for developing maternity and infant feeding partnerships and integrated work. And Laura is a qualified midwife and health visitor with extensive experience working in 2 inner London boroughs, currently serving as a clinical lead health visitor in Islington, balancing that with a clinical role 3 days a week and project work for 2 days. So welcome, Renata and Laura, and over to you.
Thank you. Thank you very much, everybody. So Bright Start Islington is the umbrella name that brings together health and early childhood services in Islington. First slide, please. Yes, this service was launched in 2017 and brought together universal and targeted service. Before that were managed at children's center level, and now they are managed at local authority level, and is a joint partnership, very close partnership with health visiting, maternity, speech and language, and a lot of other services, including CAMS and voluntary sector. The vision that you can see on this slide, the best start in life for every child, has been developed in partnership with various agencies and families in Islington, and builds on the concept of increasing resilience and decreasing stresses for families, and working in a collaborative and join-up way to do that. Next slide, please. And within that, there is a roadmap, in a way, which starts very much with maternity services, the very beginning of the journey for families coming into early childhood services in the wider sense. In this respect, Start for Life provided an extra opportunity to really focus on the first 2 years of life, from conception to 2, and strengthen the message of Bright Start. And over time, we developed, next slide please, a strategy that you can see here, the sort of strategy on a page, a slide, where again, together with our colleagues, with our families, with the voluntary sector, with all the partners that work with families with children under 5 at large, we developed a strategy for 5 years, so 2023, 2028. And that really sat very well in implementing Start for Life, the Start for Life offer in Islington. And Bright Start and Start for Life are a bit of the same thing in our borough. And as you can see in the strategy, there is a pledge to increase our and develop our partnership, and particularly a priority around developing the partnership with maternity services in recognition that that is really the first service that families that are wanting or expecting a baby come in contact with, and that's where their journey to become parents start. So next slide, please. So we started with having a strategic oversight through the Maternity and Early Childhood Partnership Board. This is a board where strategic players come together and really focus on those priorities that were developed through the strategy. And they meet twice a year. And the work done in these meetings is providing strategic direction, support, and challenge for the integrated work of the teams at large, including maternity services. Next slide, please. So in terms of the co-location and co-delivery and working closely together with maternity, we are very lucky to have two continuity of care teams based in our family hubs. Sunflower team, which is the team from Whittington, and they're based in the family hub in the north, and the University College London Hospital continuity of care team, which is based in the family hub south. These continuity of care teams have been fundamental in developing the relationship on the ground, so not just a strategic level, between a variety of professionals and maternity services. And one of the previous speakers have mentioned those soft conversations that happen when people are based in the same space, and that's very much what has been happening in our family hubs in the north and south, particularly because of the continuity of care team. So there's been a really added value for both sides of the service. Over to you, Laura. Next slide, please.
Thank you, Renata. So I'm going to talk about some of the different service initiatives we're running on the ground to aid integration. So the first slide is just talking about our health visitor and midwifery liaison meetings. So this initiative was launched with the goal of enhancing collaboration between midwives and health visitors. So a key aspect of this is regular communication. So midwives and health visitors come together every 4 to 6 weeks, and we exchange updates, insights, feedback. And this frequent contact allows us to stay aligned and responsive to each other's roles and the needs of the families that we're serving. The meetings are held both in person and virtually, and this flexibility ensures that team members can participate regardless of their location, whilst also maintaining that strong connection. I work in, excuse me, the North locality, and the continuity of care team that Renata mentioned, we actually meet face to face for our liaison meetings in the family hub. So that's quite useful to be co-located there and to meet in person there. One of our main goals is to strengthen the relationship between midwifery and health visiting services. And by fostering this connection, we're aiming to provide a more cohesive and supportive care journey for families. We've developed a standardised service agreement, and this agreement outlines the roles and responsibilities and expectations of these meetings, helping both services work together smoothly and effectively. In addition to these liaison meetings, the Transition to Parenthood team, which I'm part of, we attend an antenatal working group every 6 weeks. This meeting has representatives from health visiting, midwifery, and early years. We keep each other updated on more of a strategic level. And at this meeting, we discuss service updates and keep service leads and stakeholders updated. Next slide, please. So Journey to Parenthood is Bright Start's antenatal education course. and it's designed to support parents-to-be as they prepare for the arrival of their child, so offering essential guidance for a hopeful, smooth transition into parenthood. The course spans 6 weeks and is based on the Solihull approach. So a really key part of this course includes 2 dedicated sessions by midwives. These sessions cover essential information on childbirth and early postnatal care, helping parents feel more prepared and supported during pregnancy. Midwives play a really crucial role in this programme, not only by leading the specific sessions, but also by being actively involved in the referral process. This ensures that families who would benefit most from the course are encouraged to participate and receive the necessary support. So, whilst also running the sessions together, so midwives, health visitors and early years staff, we also attend training together. So midwives, health visitors, family engagement workers would train together to facilitate this course. So it allows us to meet each other face to face and learn together as well. Next slide, please. This slide is just about the transition to parenthood team that we have. So it's a dedicated group specifically formed to support families through the transition to parenthood. It consists of myself and my colleagues Emily and Jackie. We're all health visitors. An important feature of this team is that each health visitor in the team comes from a midwifery background. This dual experience enables us to bridge the gap between antenatal and postnatal care, providing some continuity and depth to the support we can offer to health visitors. The team's main focus is service integration. So we work together to ensure that health visitors and midwifery services are well coordinated and that we're promoting seamless care to families. We function as a central point of coordination and we facilitate communication between midwives and health visitors. This ensures that all professionals involved are on the same page and hopefully results in a more unified service for families. Next slide, please. So we have joint communication that we send out to families. We have a dedicated midwifery and health visiting newsletter, which is designed to keep everyone in the loop about the latest developments in both of our services in health visiting and midwifery. This initiative aims to improve transparency between both services and ensure that all team members are up to date. The newsletter is distributed on a quarterly basis, so we can share updates without overwhelming staff, and this regular cadence keeps everyone informed. The newsletter serves as a joint communication tool, and it provides updates, highlights best practice, and shares any changes and improvements to each service, ensuring that everyone, including stakeholders, are aligned. So as an example, one of the latest resources that we've highlighted is our new antenatal communication. This leaflet offers expectant parents an overview of services, along with key information to help them through their pregnancy journey. This is given out by midwives at the booking appointment, but it's also given out by health visitors at targeted antenatal contacts as well. It just means that all families that engage with Bright Start have the same information given to them. I also just wanted to mention the Maternity and Neonatal Voices Partnership. So this is an initiative where service users are able to directly feed back to midwives, health visitors, and service leads from both services. And it ensures that we're hearing their voices, which helps shape decision making and helps us to be client-centered. Next slide, please.
This is me again, and that's our last slide, and is bringing together all that is available for families. So most that is available for families. I'm sure I left something out, but that picture there is our antenatal leaflet that Laura mentioned that we produced together. I'm working with midwifery, health visiting, and also families. We have also a conception to 2 family engagement workers that are specifically funded by Start for Life. The antenatal pathways, the leaflet, and all the services that are available in one place for families to have easier access to information and easy access to services. We are very proud to have been reaccredited as a UNICEF Baby Friendly initiative at level 3, and that has been a joint accreditation between health visiting and early childhood, but also working with maternity. We have a new parents group that are co-delivered baby massage that is there's co-referral and co-delivery, and starting on solid foods workshops and parent baby psychology service, the first step in family kitchen, and perinatal mental health pathways. And all these services are co-delivered or have been developed together through working groups that had partnership work and multi-agency representation. So this has been our journey in Bright Start that has become even better with Start for Life, a fuller offer. Thank you.
Thank you, Renata and Laura. That's really inspirational, the level of integration you've achieved. And I'm sure many people on this webinar will be interested in your transition to parenthood team, which I think is quite unique as well. So thank you very much. Really interesting. And I know that you're constantly developing your integration too. So thank you. We're now going to move on to our final speaker, and I'm really pleased to welcome Nikki Wilson, who's CEO at Make Birth Better. Over the last 20 years, Nikki's third sector career has focused on solving strategic challenges and building organisations from scratch, including Make Birth Better, Wings for Life UK, and Read International. Make Birth Better is a unique collective of parents and professionals working together to end suffering from birth trauma. And it's built an outstanding reputation in the NHS for birth trauma training and support since they were founded in 2018. In 2024, they were recognised as one of the UK's top change makers by The Big Issues. Nikki's deep drive comes from her lived experience of postnatal PTSD and her passion for community-driven social change. Welcome, Nikki. And I know we're a bit behind time, but please take your time with your presentation. Thank you.
Thank you so much for having me. And yeah, thank you for such inspirational speakers before me, Renata and Laura. Really amazing to hear about such wonderful collaboration. So yes, let me give a bit of a third sector lens on this and birth trauma and trauma-informed practice more specifically. So really, obviously, this is me. In fact, I'll go back before I show you that. I know working in family hubs, you've all got your own personal and professional experience of trauma, the way that plays out with your service users. I just wanted to put in context for you just here at the start how Make Birth Better very much comes from personal and professional experience. So this is me 10 years ago, first time mum to Thomas. I'd very much told my colleagues at work that I was going to meditate the beep out of birth, and let's just say that didn't work. And in this photo, my very intimate dance with postnatal PTSD was really just beginning. And it's a dance much too complex for 10 or 15 minutes of your time. But among those many symptoms, there was this struggle I had with falling asleep. And I couldn't fall asleep without my mum kind of stroking my hand and just telling me I wasn't dying and saying, it's okay, this is sleep, you're safe, you're not going to die. Because after I gave birth to Thomas, I had believed I was dying. And I don't expect you to understand this, but in a funny way, I'd been waiting my whole life to die. Because my brother had died when he was only 4, too young and much too soon. And that difficult childhood experience, alongside many others, was very much kind of inked directly into my nervous system, if that makes sense. And really, trauma had always been in the background of my brain and in my body. And it wasn't until that moment that I gave birth to my first son that very much my past and present lives collided in such an extreme way, as they do for many, many people. So birth doesn't really fit comfortably in this space, does it, when we talk about trauma? Most of us choose it. Some of us have safe, positive, meaningful birth experiences, and many do pass that through that perinatal period trauma-free, you could say. But what do we do when that narrative is different, and for whatever reason the fairy tale is perhaps less magical? And in the case of birth trauma, for much too long, I'm sure you'll agree with me, it's been a very subtle but very potent narrative. At least you have a healthy baby, at least you can get pregnant again. But when we say at least, of course, we very much change the subject, don't we? We very much deny someone's reality. And the reality is that birth can feel safe, and that sometimes it can feel unsafe. And I'm not talking just about physical safety here, but very much emotional safety too. And at Make Birth Better, we believe that all of us involved in this maternity space, all those working at our family hubs on maternity services as well, can hold and have a responsibility to hold that really careful and important balance between realism and hope for a positive experience. So this is us, Make Birth Better, formed in 2018. As we said in the introduction, we're a unique collective of parents and professionals very much working together on these key areas of training, support and campaigning. And I'm really proud that in the last kind of 5 years or so, we've worked with more than 50 NHS trusts. We've got an army of dedicated volunteer champions, more than 200. We've got more than 30 organisation partners, and we have supported thousands of women birthing people and their partners through their own birth trauma journey. And of course, it's not just Make Birth Better, I must say that. There are many other wonderful third sector organisations also doing this work, such as the Birth Trauma Association, MASIC, AIMS, Birthrights. There's many of us out there who very much are here to help you, particularly with your signposting work when it comes to the support that people may need. So at Make Birth Better, we have a deliberately systemic approach. We really believe we can't achieve our mission in terms of ending suffering from birth trauma unless we bring parents and professionals together. And what's more, unless we address the kind of challenges and the trauma facing our maternity professionals, we cannot ever tackle birth trauma in its entirety. So you may agree, I hope you agree, that when it comes to birth trauma, things have come a long way in the last 20 years. Back in the 2000s, it was very much the strong belief that you could not be traumatized by birth. And then it was only 10 years ago that birth was listed as a potentially traumatic event, a potential cause of trauma symptoms or PTSD. And in those 10 years, so much has happened. I won't go through this long list of things happening in 2024 and beyond, but of course we have a multitude of services. We have a national conversation. We've had a public inquiry into birth trauma, many wonderful research projects going on, and I really encourage you to look up the BEST UK study, which is a really exciting study of more than 4,000 birth experiences that's very much going to give us some kind of post-COVID data on the prevalence of birth trauma and how that's affected by different factors such as race, culture, sexuality, gender, and other factors as well. So this talk is on trauma-informed care, and it can feel like a bit of a nebulous term, can't it? So here it says on this slide, let me just move your lovely faces to one side so I can read my slide. Trauma-informed care realises that the widespread impact of trauma. It understands all the potential paths for healing. It recognises the signs of symptoms of trauma in staff and clients and others involved with the system, and responds by fully integrating knowledge about trauma into policies, procedures, practices, settings, and all of those things seek to actively resist traumatization. Now, sometimes I don't know whether these these lovely long quotes, help or hinder. And as I said, sometimes this concept of trauma-informed care can feel very nebulous. But what we have to remember is that, you very much know this in your work, particularly in family hubs, that in fact 70% of adults have experienced at least one traumatic event. And really importantly, nearly half of people in England experience at least one adverse childhood experience. And unsurprisingly, those people are much more likely to be working in our healthcare services. So here again, just to emphasize that point, we really have to focus when we're thinking about trauma-informed care, not just about our service users or clients, as it says here. We absolutely have to be thinking about the impact of trauma on our healthcare professionals too. So what does this really mean when we're thinking about how to put trauma-informed care into action? We often joke at Make Birth Better. We love a circle, as you can see from our logo. So there are lots of frameworks that you can look up. I particularly recommend the Blackpool Better Start Good Practice Guide for supporting implementation of trauma-informed care in the perinatal period. If you put that into Google, the NHS document comes up. There is a multitude of documents you could look at. That one is particularly good for the perinatal period. But to look at things really simply in terms of how we apply trauma-informed care, we can look at different lenses. So, of course, we can look at this from a very political lens. We can look at it in terms of how we might lobby for change, in terms of investment in our services, in our staff, ring-fence funding for really important services. We're particularly keen to see our new maternal mental health services that have been developed for trauma and loss to very much remain. It's politics really that we need to influence to make sure we're getting mandated training and that we're getting really good national rollout of reflective practice for all of our healthcare professionals working in this space. We can look at that cultural lens. I think Nina very much talked to this in terms of cultures which prioritise staff wellness, collaboration, co-production. It's very much themes within our most recent guide, 3-year delivery guide for maternity services, and a multitude of other things that cultures need to do. They need to really hone concepts of autonomy, belonging, compassion, team environments where people feel that they can speak up, ask questions, raise concerns. And then finally, skills. So I thought I'd finish really just with a few practical tips and hints on how we can, in our practice, begin to become more and more trauma-informed. So, of course, that one. There we go. I was meant to do this one next. So a few practical skills here is these are the 4 signs and symptoms of trauma. They sit across all causes of trauma, and someone suffering from birth, or we really prefer the phrase perinatal trauma because there are so many factors that can cause someone to suffer these symptoms, not just the birth itself. It's really becoming more and more familiar with what these symptoms look like in the women and birthing people and perhaps babies and partners too, who are more likely to be engaged with our family hubs, particularly. Understanding what re-experiencing might look like. For me, that was, as I said, not being able to fall asleep because it felt like I was dying. Avoidance might look like, for me, it was not being able to drive down the road to the birth centre. My whole mind and body would shut down if we tried to do that. A heightened sense of threat, you will see this a lot in the women and birthing people you work with, easily mistaken just for, anxiety, but constantly feeling unself, feeling that you perhaps can't leave. In my case, I couldn't leave my own front door without having a panic attack. And negative thoughts, again, often misdiagnosed for depression here, but normally taken with these other symptoms as a strong sign of trauma being present. So in my case, I was terrified that I would accidentally harm my baby. Genuinely, truly believed I would never be the same person again. So that's a really good place that we can do more learning to become better at spotting those signs and symptoms. Oh, I see. Sorry, I can't see that slide properly. I see. So in terms of screening, it's really important to know how to screen for these symptoms. You may have heard of the City Birth Trauma Scale. Of course, traditionally in your services, you'll be using those Hooley questions, those GAD questions. What's really great is that we've been working together with the health visiting team in Kent and also with City University, who designed the scale to come up with a much shorter predictive scale. So watch this space, link in with Make Birth Better if you're interested to know. But the health visiting team in Kent, for example, are going to begin using the shorter predictive scale for birth trauma alongside Hooley and GAD. So a really nice practical way that we are going to be able to spot those signs and symptoms better. So in terms of what we can do in our NHS, looking for those opportunities for continuity of care, of course, they very much were discussed earlier, putting in place processes which mean we don't have to repeat our trauma stories. And I love, you will be seeing that in these examples of better integration. You know, we may have already told our story to a midwife, so to have to tell it again to a health visitor or someone else who's working in our family hubs. It's really important to try and capture that information and for our professionals to be talking about people who have been affected. Making sure our antenatal education is trauma informed. We're doing a big piece of work around that at the moment, really informing people of their basic human rights around maternity as you get to know them in those journey to parenthood type sessions or those transition to parenthood sessions, and having really total clarity on what your local pathway is for birth trauma support, both in terms of the NHS and the third sector as well. So here, just a reminder when it comes to the support people may be able to get if they have been affected by birth trauma. We can remind them, of course, often there is a possibility of continuity of care, though not always. There will be specialist mental health midwives, nurses and health visitors. There will be NHS talking therapies available to people. They will be and very much should be fast-tracked if they have a perinatal mental health concern. We, of course, have our wonderful new maternal mental health services for trauma and loss. Please look them up and find out more if you don't know about them. You will, I'm sure, know about your perinatal mental health teams, but also these new perinatal pelvic health services. Once again, please look those up and find out about what's going on with the local birth listening and reflection services too. We're also working collaboratively to look at how those can be improved. In the interest of time, because I really do want to leave space for this panel conversation, it's also about, you know, in terms of basic skills and practice, really knowing what are the types of therapies that are NICE approved, that people are likely to experience if they are referred on to other services. So again, spend that time familiarising yourself with the treatments and services that are available. And just to come back to that point, we're doing a very much co-produced piece of work at the moment, really looking at the subtleties of how antenatal education can really make sure it is trauma informed. We have a whole range of points, and anyone who's working on antenatal education who's here today, please do reach out because we'd love to support you with looking at how we can ensure trauma informed ways of working. So that is it for me for now. I hope I've given you a few practical things to think about and given at least a little bit of time for the panel. Thank you so much.
Nikki. That was inspirational too, and a very personal story as well alongside your presentation. And it was really interesting to hear about the City Birth Trauma Scale that you've developed. I'm sure people will be really interested in that as well. So we are going to move on for a few minutes to a panel discussion. There have been some questions about whether the slides will be circulated. Yes, they will be circulated afterwards. And if you have got specific questions, and I notice there are some very specific questions, you might want to email the presenters about those. But Grace, my colleague at the National Centre, is going to pose some of the questions to the panel.
Yeah, thank you, Jane. The first question I was going to ask was about multidisciplinary team training. And it relates to Nina's point about the value of learning together and getting more insights into other professionals and services in the family hubs. And the question was, are there any examples of multi-agency learning programs in family hubs that bring professionals together to learn from their experiences? But also on that same thread, in alignment with Jess's example of the anti-racism training happening in Bristol, there's a question of how that training has worked and the feedback you've received from it.
Should we start with Jess and the specific question to Jess, and then ask the panel more widely about interagency training in family hubs, bringing people together? So Jess, do you want to go first?
Yeah, sure. So the Black Maternity Matters, although it was originally focused on maternity, subsequent cohorts have actually been much wider than that, because obviously there's a clear need across different disciplines for anti-racism and cultural competency training. And that's been really positive. They've had a senior leaders cohort, which has enabled things, things to be looked at from quite a strategic perspective. The interim report was focused, I'd say, probably on the kind of things like the feasibility, acceptability of sort of delivering cultural competency, anti-racism training using an quality improvement approach. So it's kind of looking at things like increase in participant skills, knowledge, impact on practice. But it was highlighted in that report that subsequent evaluation needs to focus on the kind of impact and outcomes for Black women in terms of their sort of birth and pregnancy risk factors. So hopefully that answers that.
Thank you, Jess. And Renata and Laura, do you want to comment on any training that brings staff together? And then maybe Nikki, who also provides training to the workforce. So Renata, Laura.
Yeah. So as Laura said, obviously the journey to parenthood is a training that is multi-agency. We also have other training that are delivered in a multi-agency way. For instance, trauma-informed practice training, as to go on and continuing what the last speaker was talking about, is purposefully multi-agency, so that we create a language and a culture and an understanding that is shared amongst different people that work in and around family hubs on how to approach clients, approach the general public comes through the door in a trauma-informed way. So that's another example in Islington. Sure, Laura, there is more. I can't think of anything at the moment, but most of our training is, in a way, multi-agencies, is sort of promoted through the local authority platform, but accessible to all professionals working in Islington.
Yeah. Sorry.
Sorry, Laura. No, that's fine.
I was just going to say about the trauma-informed training, and as Nikki was speaking, that was on my mind, thinking of that. We've got a session coming up in a couple of weeks, which is for midwives and health visitors and all other staff there. And I think it is really important that we're all receiving the same message and delivering the same message. And then, our journey to parenthood facilitator training. Midwives and health visitors are on those courses, as well as family engagement workers, family health advisors. So it's a real multi-agency thread there.
Yeah, thank you. Nikki, do you want to add anything to the teams that you train?
Yeah, it's very variable for Make Birth Better. We have historically had a lot of commissioning from our mental health services and our maternity services, understandably, often together. So we definitely see an MDT approach. For example, within midwifery, it isn't just the midwives. We do get the obstetricians, and all of the others as well. We are now beginning to train health visiting teams, but that's only just beginning. We've probably only had a handful out of all the training we've been doing where we have had midwives and health visitors in the same room. Which is a real shame in many regards, but we would love to do more and more of that. I think with birth trauma specifically, obviously there are certain things that are probably slightly profession specific for midwives particularly, but it is so powerful when we get all of the different professional groups together, because they begin to see the links. With something like perinatal trauma, it is very much something that all of those involved in that journey need to be integrated on. So the more MDT training, the better, as far as we're concerned.
Thank you, Nikki. I just want to add too that Merton in London, and I think Carolyn Castle's on this webinar, have developed a really strong workforce development strategy for their family hubs and train their workforce together. So if anyone's interested in hearing more about that, if you email me, I will put you in contact with Carolyn. I'm sure she won't mind. And they'd have other shared learning platforms as well for their staff, which is really useful. So moving quickly on, because we're out of time, we've probably got time for one more question. Well, we haven't got time, but we'll take it.
Yeah, and there's a lot of questions about data sharing, but we can address these afterwards as well. But final question on funding. It's a policy question relating to the Start for Life and Family Hubs funding. Is there any information about funding support for the local areas that weren't part of the original 75 areas in receipt of transformation funding?
That's to you, Becky.
Yeah, thank you. So nothing that we can share at the moment. Obviously, we know that 69 million has been allocated to develop family hubs for those who are already on the programme. But there are obviously lots of conversations, lots of looking at evidence now, looking at outcomes that we've got from the 75 currently on the programme, and lots of conversations about how family hubs could move forward in the future, but nothing concrete that I can share with you, unfortunately.
Thank you, Becky. So finally, to sum up, we're a minute over. I just wanted to say thank you, first of all, to my colleague Grace Bapty, who pulled this agenda together and did a lot of work on pulling it together. And secondly, to all the speakers who've created a really thoughtful morning, actually, and put a real focus on what we can achieve. And that we really need to do that together, collectively, collaboratively, if we want to address these inequalities that have been well documented now in maternity services, and that family hubs, as I said at the beginning, gives us that opportunity to do that. So thank you, everyone. I'm sorry we've run over by 2 minutes, but yes, it's been a really thought-provoking morning. Thank you very much.